PPD, about vaccines, about where you were born, and I thank you for sharing these stories. I think we'll have a little bit of time here, so I want to make clear that the person that has the PPD positive test and has a negative chest x-ray could still be a carrier of tuberculosis. Is that clear? So the chest x-ray is done to see if you have an active infection. Remember, not everyone with TB gets pulmonary TB even. Okay, so I said there was a number, something like 15% may not get pulmonary TB, but they have the bacteria in their body. And so that chest x-ray is to really to see if you have an active infection right now. That doesn't necessarily mean that you're not a carrier. So, so some people in this country are carriers. We don't vaccinate against this here because it's not a huge epidemic in the population, whereas some of these other countries vaccinate because it is. Okay, so that's kind of the difference in vaccine policies. We do enough vaccinating here, I think, without adding another one. What else? Any other questions? Some interesting discussions. Yeah. All right. So let's move on. The TB infection. If you look at the lungs, here's my little alveoli. Here are the bacilli, these mycobacteria and bacilli. And essentially what you're going to see is inside these alveoli, you're going to get a very rigorous immune response when these bugs are in the alveoli. And so essentially what's going to happen is that the bacteria are picked up by dendritic cells. These dendritic, not dendrites like the neurons, but dendrites, the dendritic cells of the immune system. So the bacteria get picked up by these dendritic cells, which are always circulating in the pulmonary alveoli. These bacteria will okay, so I kind of messed that up. These bacteria, these are not the dendritic cells, these are the macrophages. Okay, so these are macrophages. The dendritic cells haven't come yet. The macrophages are the first cells, as I said earlier. The macrophages are the ones that are circulating in the pulmonary alveoli. So the bacteria are going to be in those macrophages where they can replicate. Okay? You see that? So the first set of cells here are the macrophages. Now here comes the dendritic cells of the immune system. Okay? So the dendritic cells then come into the mix and pick up these bacteria that have replicated within macrophages. So remember, these macrophage cells that are laden with the bacteria are what's going to form the tubercules that allow us to visualize them on the chest x-ray. Now these dendritic cells of the immune system can come in. Part of the role of dendritic cells in the immune system is to take things to the lymph nodes. And so that's exactly what they're doing. They're just doing their job. So they take, these dendritic cells take the bug then to the lymph nodes. And so here, essentially, the bugs can escape as the dendritic cells are residing in the lymph node, and the bug escapes from the lymph node, now look, into other tissues. Okay? Other tissues. So this is how it disseminates into the other tissues. Now I've condensed this and made it much simpler than it is. Some macrophages have the ability here to kill, if the macrophage is activated, to kill the bugs. If the macrophages are activated, the bacteria can be killed. If a person has this infection in their lungs, at this point they have started making antibodies. Okay? However, if their macrophages are activated, and this is based on a whole complicated immune response, the bacteria will be eradicated. This person will always test positive for TB with the PPD test, though. Does that make sense? So now they have had TB, the immune system has defeated it, but the antibodies are lifelong, and the PPD test will be positive. So this person is no longer a carrier even of TB. Make sense? So this person is not carrying TB. They've had the infection. It's been cleared by the immune system, and they're going to test positive. This is not what happens in most people. Most people's immune systems don't activate macrophages to such a degree that the macrophages can clear the infections. So in most people, it does kind of linger. Okay, it's not cleared at this point. Now, the other big point I want to make, in most people, it doesn't disseminate either. It just stays in the lungs. Okay? So this dendritic cell that has moved this bug from the alveoli into the lymph nodes is really going to happen in children or immune-compromised people, where we see the dissemination of TB. Okay? Everyone clear on that? I botched that macrophage thing up. Everyone clear on that? So these are the macrophages. These are the dendritic cells. Two different types of immune cells. All right. So when the infection is active, the symptoms can include chest pain, coughing up blood, a cough that lasts greater than 3 weeks. It's, again, generally a productive cough. A quarter of the cases, again, often in immunocompromised children or elderly, is going to spread to these other sites. Okay? Once something gets into the lymph node, I mean, the lymph node pretty much, the lymphatic system pretty much parallels the circulation. Okay? So from the lymph node, it can get anywhere. Extrapulmonary TB is not going to be spread easily person to person. But if the infection occurs along with the pulmonary TB, it will be. Remember, it's person-to-person spread, mainly by sneezing, coughing, talking. Okay? So if a person has genital TB, it's not going to be spread by coughing, unless it's also in the lungs. Okay? All right, there is a classification system that CDC does for TB diagnosis. And so you can see the classes here, 0 through 5. So just look at this from the standpoint of 0 being no TB exposure, and this person is not infected, so there's no history of exposure, a negative reaction to the PPD test. Class 1 is the TB exposure, so they have some type of history of being exposed. This could be having a family member that had been diagnosed with TB. It could be being on an airplane that the CDC recognized was the cause of a TB outbreak, which is very common actually. Sometimes you'll be walking through an airport and there'll be someone with a mask on, right? Stay away from those people. These are people that have active TB that are traveling. Okay, and so by law in the U.S. they should be wearing a mask. However, other countries aren't as stringent in enforcing these type things. Okay, so class 2 is a TB infection but no disease. This is a positive reaction to the PPD test. There's no bacteriological evidence. Okay, what does that mean? A positive reaction to the tuberculin skin test, but there's nothing in the sputum or in the urine or other tissue. So no clinical, bacteriological, or radiographic evidence of active TB. So there's no chest x-ray that's positive even. Okay? Class 3, TB that's clinically active. So this is cultured and present. Okay? So cultured sputum reveals the presence of the bacteria, cultured urine, cultured blood, cultured stool, something like that. Okay? TB is not part of the normal flora, so it shouldn't be in the stool, in the feces. Class 4 is TB that's not clinically active, so you can see what that entails. This is not usual. This is not usual. And then Class 5 is where a diagnosis is pending. So that some of these tests are done. The patient is based to based on symptomology, suspected to have TB. All right, if we look at the anti-tuberculosis drugs, the first-line drugs are shown here. We have not really talked about any of these, have we? No. Okay. The second-line drugs are shown here, and we have discussed some of these. Okay. Streptomycin is one that we've discussed. Amikacin is one that we've discussed. Kanamycin won't be available in the U.S. Capreomycin we have not discussed, but levofloxacin, moxifloxacin are available, and we have discussed these as covering TB. Gadifloxacin, again, I took this slide from CDC. This is no longer on the market as an oral drug. So what we're going to talk about today is really these first-line drugs that are that we have not discussed yet. Isoniazid, rifampin, pyrazinamide, and ethambutol. Not specifically in this order, but these four drugs, remember them as RIPE. Okay, so rifampin, isoniazid, pyrazinamide, and ethambutol are going to be kind of your first-line choices here. Okay, rifabutin and rifapentine are going to be rifampin derivatives that can be used. I'll show you when they can be used. Okay, so RIPE. Pretty easy if you remember it that way. Why would these two fluoroquinolones be useful against TB? They're very penetrable, okay? Good lipophilicities, and they are going to be able to penetrate into the cells. Specifically, what type of cells? So the macrophages, or those dendritic cells that have engulfed the bacteria. All right, let's talk about isoniazid first. This is kind of the first of the first-line therapies. Isoniazid goes back to the 1940s. It's going to be highly selective for all four of the Mycobacteria species. And after treatment of Mycobacteria tuberculosis with isoniazid, the bacteria loses its acid fastness. So remember what we said acid fastness was? So what does this suggest to you? If it loses its acid fastness after treatment with isoniazid, what does that suggest isoniazid is doing? Yeah, very good. So it's doing something to that thick cell wall layer that we talked about, right? Those mycolic acids specifically. So it's doing something to those mycolic acids. We'll talk about that in a sec. This can penetrate host cells. It's lipophilic enough to penetrate host cells with ease. Again, the importance of that should be clear based on what I just said about levo and moxifloxacin. You want lipophilicity enough to penetrate those macrophages, those dendritic cells, or other host cells that these bacteria are hiding in. All right, if we look at the mechanism of isoniazid, the mechanism of action, isoniazid here is going to be metabolized by catalase peroxidase, which is a mycobacterial enzyme. So isoniazid is essentially a prodrug. It's metabolized by mycobacterial catalase peroxidase to reactive metabolites. Okay, so this is a mycobacterium enzyme. It's not a human enzyme. It's going to be metabolized to these species, which then two of them can be further metabolized. The three that I've shown you here in red are active byproducts, the active metabolites. These three have electrophilic groups that can act as acetyl donors. You guys remember acetyl donation. We talked about aspirin is a drug that covalently acetylates. It donates the acetyl group to cyclooxygenase, right? So these three drugs have electrophilic groups that can donate this acetyl moiety here to something. And we're going to talk about what that something is on the next slide. So in general, this drug is very well absorbed by mouth or IV. It's lipophilic enough to penetrate all cells and tissues. All right, so CAT-G is the gene that encodes for catalase peroxidase. So sometimes in the literature you see isoniazid and CAT-G. Sometimes you see it as catalase peroxidase. I use both of them here so that you know if you see one or the other, it's the same thing. So essentially, the mechanism of action of this drug is going to work to inhibit mycolic acid synthesis. Now look what happens normally. So this is the normal situation in the mycobacterium. So CAT-G doesn't really do anything here yet. So fatty acids are going to bind to another mycobacterial enzyme, INHA. Okay? So fatty acids will bind to this INHA. This is a tuberculin enzyme. It's a reductase. And essentially what this does is it reduces fatty acids to mycolic acids. Okay, so this is how the tuberculosis organism is making those hallmark mycolic acids that it sticks into its membrane. Make sense so far? Yeah? So if you understand that, then the rest should be easy. So INHA is the enzyme that tuberculosis uses to make mycolic acids from fatty acids. So here's how the whole mechanism put together is going to work now. So isoniazid in the mix here. Isoniazid gets into the bacteria. Remember, CAT-G is the bacterial enzyme that's going to convert isoniazid into those reactive isoniazid metabolites that I showed you on the last slide, right? So once CAT-G has converted isoniazid into these reactive metabolites, what do you think it's going to do? It's going to go over here and bind to INHH and essentially acetylate it. It donates itself to it. Make sense? Now, INHH, its normal function in this bacteria is to take fatty acids and convert them into mycolic acids. But when it's been acetylated by this isoniazid metabolite, here comes the fatty acid, it can't get into the active site. And so what happens to mycolic acid synthesis? It decreases. Without mycolic acids, the membranes of these bacteria are structurally not sound. So without the mycolic acids, the membranes aren't sound and the bacteria cannot survive. This is a high degree of selectivity target. Isoniazid is very selective. Why? Because both of the enzymes are bacterial-only targets. We do not express either one of these things. Okay, so high selectivity. The one side effect that is pretty pronounced of these agents, if you guys recall, we talked about Mayo inhibitors in nervous system 1. Mayo inhibitors came from iproniazid, which is derived from isoniazid. Isoniazid has some affinity for human monoamine oxidase. Okay, so that's the one kind of non-selective effect. It's very selective for the bacterial targets, but it also can bind human Mayo. So slight Mayo inhibition properties. How is resistance to this drug going to occur? Okay, yeah, so changing of mutation of the catalase peroxidase can do it. Deletion or underexpression of the CAT-G gene. If the bacteria get around having or needing CAT-G, they mutate it, then isoniazid cannot be activated. So many of the isoniazid-resistant isolates have decreased CAT-G activity. due to either underexpression or excuse me, deletion of the CAT-G gene. So in those bacteria in the lab, those bacteria that have this deletion or underexpression of CAT-G, they're resistant to isoniazid. You can give them isoniazid and it won't do anything. But if we reintroduce through molecular means the CAT-G gene into those bacteria, then they die in the presence of isoniazid. So mainly it's mutations to CAT-G. All right, some important considerations to be made for isoniazid. Today is generally going to be used alone for prophylaxis of active TB. So it will prevent the carrier from developing an active infection. And it will be always used in combination for treatment of active disease. So it can be used alone for prevention of active disease, but always in combination for treatment, and that is due to resistance. Isoniazid can cause peripheral neuritis, and this is done due to the depletion of pyridoxine. What is pyridoxine? B6. So oftentimes you'll see it given concurrently with pyridoxine to prevent that neuropathy. This is a dose-dependent neuropathy. You can see 2% incidence in those given 5 mg per kg per day, 10 to 20% if the dose increases. So as you give more isoniazid, the chances of causing this neuropathy are increased. This is important in patients that are already have some type of neuropathy, like late stages of diabetes or so on. This drug is metabolized by the liver, particularly by the enzyme N-acetyltransferase 2, NAT2. Okay? N-acetyltransferase 2. There's a variable distribution and activity of NAT2 genes and NAT2 proteins. So we talked about this intrapersonal variability a couple days ago, last week. So NAT2 is another one of these genes, like the CYP3A4 gene, that can be expressed to different levels in different people. There are 36 different alleles of the NAT2 gene, so that is, provides a lot of genetic variation. The rate of acylation of isoniazid can be variable due to the variable expression in NAT2. The rate of acylation can vary, and the rate of acylation will profoundly affect the drug concentration and the half-life. Okay? Isoniazid itself is the active one that we want, right? Because this is the one that the bugs are going to take up and convert into the reactive metabolite. NAT2 adds this group, this group here through this acylation. And NAT2, if it's high, okay, so I'm going to use some friends over here again. I don't have my friend Jared. All right. So Blake is a high expressing NAT2 person. Okay, he's got a lot of NAT2 genes, so he's got a lot of NAT2 protein in his liver. So if we give Blake isoniazid and he's got a lot of NAT2, what's that going to mean for the concentration of isoniazid in his blood first? It's going to be lower than someone else may, right? What's that going to mean for the concentration of the acylated metabolite? It's going to be higher, right? So he's fast acetylator is what we call him. Fast acetylator of isoniazid. The fast acetylators will have more NAT2, so they're going to quickly acetylate isoniazid. This is important because you are going to, in him, have less isoniazid. Okay? There are also slow acetylators, so people that have a relatively lower expression of NAT2. So in slow acetylators, you're going to have a higher concentration of isoniazid and a lower concentration of the metabolite. All right, the problem with this occurs because the acetylated version, the acetylated metabolite, can cause hepatotoxicity. So who is expected to get hepatotoxic side effects? Fast acetylators. So people like Blake that have high NAT2. Okay? You understand that? Yeah, I'll say it again. So people that have highly expressed NAT2 are going to be fast acetylators. They're going to have less isoniazid in their blood, but more of the acetyl metabolite. The acetyl metabolite causes a degree of hepatotoxicity. So those fast acetylators are going to be expected to have a little bit of more hepatotoxicity compared to slow acetylators. Neuropathy is more frequent and a bigger problem in slow acetylators because isoniazid itself is linked to the neuropathy. Okay? So we got two side effects here that I brought up. Neuropathy as well as hepatotoxicity. Neuropathy is due to the isoniazid parent. You'd expect to get more of that in slow acetylators, right? Because they're going to have more of this than of this. Hepatotoxicity is more prevalent in fast acetylators. And again, that's linked to the acetyl metabolite. You guys with me? While we can test to see who may be a fast or slow acetylator, where you come from and what your ethnicity is also predictive. So fast acetylators predominant in Asia, and particularly the Far East. So China, Japan, Korea, the Far East. So those people are typically, based on their genetics, fast acetylators. Slow acetylators are predominantly going to be North African Caucasians or Europeans. Descent. Okay, so this is a genetic analysis, not necessarily a population-based analysis, which is why it doesn't include America, because America is relatively young still as a genetic population. It's a little bit difficult to say, because there's so many Europeans here, there's so many people of different cultures and different ethnicities. It's still hard to say genetically if we're fast or slow for the most part as Americans. Okay, but people from the Far East are generally fast. People of European or North African descent are generally slow. Okay. The other predisposing factor is age. The younger you are, the less risk. So people under 20 have almost no risk. People greater than 50 will have a little bit of a higher risk. We got to take care of that. Risk of hepatotoxicity. Risk of hepatotoxicity. All right. Any questions about isoniazid? Yeah. This is an inactive metabolite because remember the bug makes the active metabolites. Yeah, so under the age of 20, the literature says that there's really no risk at all for hepatotoxicity. It doesn't matter if you're fast or you're slow, really. Okay? But as you increase in age, then that NAT2 expression becomes a little bit more important. All right. Let's move on to the other really big drug for TB, rifampin. Rifampin belongs to the family of rifamycins. Okay, and rifamycins And rifampin specifically can be used for TB or for MAC, the Mycobacterium avium complex, which you're going to start seeing me say more and more as we get closer and closer to HIV. Rifampin is branded as Remactane alone, or Rifamate, called that because it's mated with isoniazid. Okay, so it can be given in that one dose. It's going to have a good activity against most gram-positive and many gram-negative bacteria as well. So strep and staph included, not MRSA. Here's Neisseria and Haemophilus influenzae. So kind of a broad spectrum, and in fact, this can be one of the drugs used against CRE as well. So it's a broad spectrum in a bacterial activity, but very good at treating these mycobacteria. Look at the MIC for Mycobacterium tuberculosis, anywhere from 0.005. That's the most potent drug we've talked about as far as MIC goes. So 0.005 to 0.2 micrograms per ml. It does have synergy with streptomycin as well as isoniazid, so it increases the activities of both of those drugs against TB. It will be used exclusively as a combination treatment due to the fact that resistance can occur rapidly. Of course, the importance of lipophilicity here is going to be obvious. You've got to get the drug into the bacteria, and you've got to get into the cells where those bacteria are residing. Yes? Kind of a unique mechanism here. So the mechanism of rifamycins, and again, remember, rifamycins is the class. Rifampin is the first specific drug I'm talking about. But they're all going to share this same mechanism. By the way, this is a good time to point out rifamycin. I've brought that up at one point already in the course. What did we say about rifamycins? They will absolutely do what? Decrease the OC concentration, the oral contraceptive concentration. Okay, so these are the drugs I'm talking about. All right, so the mechanism of these is a little bit unique compared to anything we've talked about. So here is the DNA, right, in a bacteria. And bacteria have what's called a DNA-dependent RNA polymerase. And we have this enzyme too, right? So what does that mean to you, DNA-dependent RNA polymerase? That means it depends on DNA to make RNA, specifically mRNA. So if you look at this DNA polymerase, it's a multimeric enzyme. It's got different pieces. So it's going to zip across this DNA, and as it does so, it's going to encode for a complementary mRNA. And then from that mRNA, as you know, the bacteria will get their proteins. Well, the drugs, rifamycins, will bind to and inhibit this DNA-dependent RNA polymerase. So in this case, the bugs will not synthesize mRNA, and if they can't do that, they can't synthesize proteins. This leads to bactericidal activity. Now, selectivity of this drug is fairly good at the doses we use it, but if patients start taking now high doses of rifamycins, what's going to happen? You're going to start inhibiting mammalian DNA-dependent RNA polymerase, which is very bad. Okay, but again, at the doses we use it, very selective. So that's the mechanism. Some of the untoward effects, GI disturbance and rash, are the most common. It is potentially hepatotoxic, so caution is used in those with history of hepatic dysfunction. This drug has the ability to change the color of the skin to an orange pigment. And it also, in contact lens wearers, can change the color of the contact lenses to an orange color. And so this is something that you may want to tell patients not to be concerned if they start turning orange. It's not that extreme. You're not going to look like a pumpkin. But for certain, there can be a tinge of orangeness to the skin, and particularly the contacts will change color. All right, this drug is a potent inducer, underlined and bolded, of CYPs, 3A4s, and 2Cs. Could decrease the effectiveness of, well, we already said they absolutely will decrease the effectiveness of this, oral contraceptives, right? Why is that? Because it's going to induce 3A4, and oral contraceptives are metabolized by 3A4, so you're promoting the metabolism of ethinyl estradiol. Okay? Very simple. You're promoting its metabolism. All right? Corticosteroids, warfarin, clarithromycin, azole, antifungals. Now this is a big one here. Rifampin, based on its induction of CYP3A4, will promote the metabolism of reverse transcriptase inhibitors and protease inhibitors. So we avoid using rifampin in HIV because these drugs are going to be critical in HIV. Okay? Again, due to the fact that it induces CYP activity. So if a patient's on protease inhibitors, if a patient has HIV, they are on multiple protease inhibitors and RT inhibitors. And if you induce their metabolism, they're not going to suppress that HIV. Okay? So we don't use this drug specifically, but we can use other rifamycins, as I'll tell you in a minute. If you look at resistance in the United States, it has held steady for isoniazid up here. So isoniazid is an older drug, so there's going to be more resistance, obviously, to that. So about almost 10% of isolates of TB are resistant to isoniazid. What we have now is multi-drug resistant TB, which multi-drug resistant in this case means resistance to rifampin and isoniazid. Okay, so those two drugs. And that's also held pretty steady the last 10 or 15, 20 years. So MDR-TB, the reason why I bring this up now is because that means resistance to the two drugs we've talked about. Resistance to rifampin can occur 1 out of every 10 to 100 million bacilli are going to be resistant. Usually occurs in patients who have received prior therapy with rifampin. Essentially what happens is you get alterations to, remember I said this DNA-dependent RNA polymerase contains many subunits. One of them is the RPOB subunit down here, and you get mutations to several of the codons of that subunit, which reduces binding of the drug. Monotherapy of rifampin is going to select for resistant organisms. So what I mean by that is that in any given case, let's say 1 out of every 10 million organisms in a patient, let's say a patient has TB and they have 10 million organisms. One of them is resistant. Okay? If you give rifampin by itself, you're going to kill these other ones, but that one is going to start growing. And you're going to now select for that resistant population in this patient. Does that make sense? We don't want to do that. We want to kill that one too, so it's always used in combination. Never used alone due to the fact that it selects for resistant organisms if you use it by itself. Any questions about rifampin? So I want you guys to be familiar with all of these drugs because there's other rifamycins, but remember that rifampin's main, we talked about a couple problems there, the orange pigment and stuff like that. I want you to remember that rifampin's main issue for you is going to be its use in HIV. It's not done. Okay? Rifabutin is similar to rifampin. It has better activity against MAC. There is cross-resistance between rifabutin and rifampin for TB and MAC. The difference here is that it doesn't induce CYP to the same degree as rifampin does. So it can be used in those HIV/AIDS patients that are on RT inhibitors or protease inhibitors. Okay? So rifampin is not, but rifabutin can be. Okay? So it's a less potent inducer. It still induces it, but much less degree that rifampin induces CYP. And interestingly, even though there's cross-resistance, about a quarter of rifampin-resistant TB are rifabutin sensitive. Okay? So just because rifampin has failed doesn't mean that rifabutin necessarily will. And there's one more of these. Rifapentine is going to be essentially just a longer acting version. Another rifamycin that is going to have a longer half-life. That's the only thing I'm going to say about it. Rifapentine is going to have a 13-hour half-life, whereas rifampin is on the order of 2 to 5. Okay? So nothing different about this as far as the use goes, or the coverage goes. The mechanism, everything's really the same. The half-life is the only difference. Yeah. So rifabutin's the main one in HIV. Okay. So rifapentine, due to its longer half-life, can have a more variable effect on CYP. Okay. So it can be used, but you're not, based on the fact that this is so well, you're not likely to use it. Okay. All right. Here's a drug that has no home. This is a rifamycin, but is a non-TB rifamycin. And so I have no place to put it, so I put it here. This drug does not fit into the TB treatment regimen at all, but it is a rifamycin, so I bring it up here. Okay. This drug has one use, indicated for the treatment of traveler's diarrhea caused by E. coli only. So this is kind of like one of those educational distractions. We're going off kind of on a tangent. E. coli only. Okay, just remember the name. Okay, if you see this drug and it's new, so you're more than likely to refer to it by its brand name. Xifaxan is really going to only be used for E. coli, traveler's diarrhea. Okay, there are some indications that it may be useful in preventing TB-active infections. It is currently under trial for it, but not useful for TB as of February 1st, 2013. Okay, so just know that this one drug is really out there in its spectrum, only E. coli. All right, let's take a break to the top.